Lumbar puncture describes the placement of a hollow needle into the subarachnoid space of the lumbar spine in order to obtain cerebrospinal fluid, or CSF, for diagnostic and/or therapeutic purposes. LP is a useful tool in the evaluation of critically ill patients. The indication for the procedure may not be apparent on a patient's admission. However, once on the ICU, many CNS pathological processes cannot be distinguished or appropriately managed without examination of the CSF. Proficiency in this technique is therefore essential for practitioners in the ICU. This module will describe the indications, contraindications, techniques and troubleshooting, analysis and interpretation of results, and complications of lumbar puncture in critical care. CSF examination is performed for diagnostic or therapeutic purposes. LP has an integral role in the diagnosis of CNS infection or inflammation, neoplasm, and pressure-related disorders. Despite advances in CNS imaging quality and availability, LP retains an important role in the workup of subarachnoid hemorrhage. Therapeutic indications for LP include the administration of antimicrobial and chemotherapeutic agents and short-term relief of certain disorders of raised CSF pressure. However, studies of therapeutic LP in ICU patients are lacking. The reduction in lumbar CSF pressure from LP, resulting in brainstem herniation in patients with raised intracranial pressure, was postulated to be responsible for early post-LP deaths in the 1890s. Consequently, raised intracranial pressure as determined by presence of clinical signs such as focal neurological deficits, altered conscious state, and seizures have been considered a contraindication to lumbar puncture. CT signs of raised ICP have also been considered as a contraindication, though their significance in the absence of clinical signs is unknown. A normal CT is unable to exclude raised ICP, though once again the significance of this is unclear. Although lumbar puncture may be safely performed in many patients without imaging, most patients presenting to ICU would satisfy the recommended criteria for imaging pre-lumbar puncture, such as impaired conscious level, seizures, localizing neurological signs, or immunosuppression. For those who do undergo CT, it is becoming clear that brain shift on imaging in the context of symptoms lasting hours to days is the most accurate absolute contraindication to LP, whether the CSF pressure is raised or not. In short, the presence of signs of raised ICP with associated shift on CT should be considered an absolute contraindication. The second contraindication is bleeding diathesis. Significant coagulopathy or thrombocytopenia are intuitive contraindications. However, there are little data on the safe level of platelets, INR, or APTT at which lumbar puncture can be safely performed. Drugs convey a bleeding risk also. Some authors suggest LP is safe in the context of aspirin use. However, in the ICU population, with the use of larger bore needles for diagnostic purposes, evidence-based guidelines are in short supply. The 2012 radiology guidelines suggest the withholding of clopidogrel for at least 5 days prior to lumbar puncture. The decision to perform a lumbar puncture in the context of coagulopathy should be considered against a reasonable assessment of the expected benefit to that patient. In patients with suspected spinal epidural abscess, LP is contraindicated due to the risk of introducing organisms into the subarachnoid space. Superficial infection of overlying skin is deemed a relative contraindication.